I'm going to talk in the first of the three talks about the newer drugs. And by the newer drugs, we essentially mean everything except imatinib. Before I move on to talk about the newer drugs, I think it's helpful to understand where we came from and what the older drugs can do. And then I'm going to talk about using the newer drugs either as the initial treatment, which is increasingly common around the world, using them after imatinib is no longer giving a successful response, and using them after a couple of drugs have failed. So some of you, I was reading through the book before, some of you have even been on interferon. So interferon was the best treatment for CML until the invention of Gleevec. So until the 1990s or early 2000s, most patients were started on interferon. And these are survival curves. I hope that you've all seen these before, but just to explain briefly, this is 100% at the start, so 100% of people were alive when they started the drug. And then you can see as the line drops, that means that people were dying, mostly, of course, from their leukemia. So you can see that after 5 years, around half of the patients had died on interferon treatment. This line here is interferon plus cytarabine, so that was a combination of two different drugs, which was slightly better than interferon on its own. So you can see until the 1990s, the average life expectancy for CML, if you couldn't have a transplant, was about 5 years. So things have come in an enormous way since then. We learnt very quickly with interferon that if you had a cytogenetic response, so if some of your Philadelphia chromosomes disappeared in the bone marrow, that this meant that you were going to do better in the longer term. So in the curve on the right, you'll see here that these people had a major cytogenetic response, which means that less than 35% Philadelphia positive cells in the bone marrow after a year of interferon treatment. And you can see how much better this curve looks, where more than 90% of people are still alive at 5 years versus the 50% in overall patients. So having a cytogenetic response made an enormous difference to the outcome of treatment. Many years ago, the Germans, who've done a lot of research in CML, did a study comparing drug treatment using the best available drug at the time, which was interferon, versus allogeneic stem cell transplantation if you had a matched related donor. And so here we see the curve for people who had no donor, so they continued on interferon. And here the black line is people who did have a donor, and so they got transplanted. And what you can see is that although the curves look slightly different, they basically run fairly closely together, and after about 10 years there was absolutely no difference. So what this tells us is that interferon and allogeneic transplantation were roughly equivalent, and interferon was maybe a little bit better than transplantation because of the people who died in the first year or two after their transplant. Now, when you consider how much better imatinib is than interferon, allogeneic transplantation should no longer be thought of as the first line of treatment for CML in adult patients. And so then moving forward, I guess, into what we would consider to be the beginning of the modern treatment of CML with the IRIS study, which Pat introduced before. So you think back to the slide I showed a couple of moments ago and see how much better these curves look, where well over 90% of people are still alive after 5 years versus around half of people. And the other important thing to point out is that if you look at people who died from CML versus people who died from other causes, it's roughly 50-50. So if you started imatinib in IRIS, you were just as likely to die from a car crash or a heart attack or whatever as you were to die from your CML. So that's already an immense improvement in survival. And then if you look on the right-hand side, similar to the interferon curve, this is divided up according to how you were doing after about 6 months of treatment. So if you had a major cytogenetic response, you're in these two curves here, which are running around 95%. So if you've done well in the first 6 months, you're almost guaranteed to do well in the longer term, and this curve runs out to 6 years, and of course we now have even longer data from IRIS. The other very important thing to know about imatinib and about TKIs more generally is that when things go wrong, they mostly go wrong in the first year. So this is looking at adverse disease events, and this is looking at progression to accelerated phase or blast crisis. So most of the people who progressed to accelerated phase or blast crisis did so in the first year after achieving a cytogenetic response. And then every year after that, the risk is less. So what this tells us is that it's very important to get good control of the disease in the first couple of years. If you've made it through the first 2 or 3 years and things are going well, the chances of things going wrong after that are very, very low. So the beginning of treatment is really very, very important. And as time passes and you see what your response is like, you can be more and more confident of the long-term outcomes as well. So to summarize this first sort of historical section, we've fairly confident that TKIs are better than any other treatment for CML. People who have deeper cytogenetic or molecular responses always do better. And this improves survival, and it improves the risk of progression to accelerated phase or blast crisis. And already with imatinib, most of the people who die on imatinib actually don't die because of CML. They die because of the other things that happen to us in life. Being on a TKI doesn't mean that you'll live for 1,000 years. You may still die from the other things that we're all susceptible to, but the chances of dying from the leukemia are now very, very small. This slide really is about the way that we think that CML behaves. So every leukemia and every cancer has to somehow begin with just one malignant cell. So here I've put in the first box, these are the leukemic stem cells, and they're probably very small in number. We think that true leukemia stem cells are probably maybe only a couple of hundred cells in the body. And then the leukemia cells mostly just sit there to be permanent sources of the leukemia, and a few of them go on to grow into more mature cells, which we call progenitors. And then this progenitor population in turn, some of it goes on to mature, and some of it sits there as a reservoir for the leukemia. So this is how the leukemia grows. It starts from one cell, they gradually expand, and then they eventually come out to the stage where they fill up the whole of your blood. Why this is important is because when things go bad, when it turns to accelerated phase or blast crisis, it's not here with the millions of cells that you have in your blood, and it's not here in the 100 or 200 of stem cells that are very, very hard to measure. It's actually in this in-between population. And what this means is we think that if you can reduce this population to be very small, or maybe even get rid of it altogether, then you can stop blast crisis from developing. And if you never get blast crisis, you probably won't die from your CML, because the reason why people die from CML is almost always because of accelerated phase or blast crisis. You can live with chronic phase for many, many, many years. But people who die from CML mostly die because they've transformed. And that means that we have to get rid, first of all, of what's in the blood, and then later this progenitor population. So living a long time with CML doesn't mean you have to get rid of everything, but it probably means that you have to get rid of this box and this box here. So how do we measure how much leukemia is left? So you've seen graphs similar to this one. So in a standardized laboratory, we set an average value at diagnosis of 100%, and then a 1 log reduction, 10%, is approximately equivalent to a partial cytogenetic response, which is less than 35% Philadelphia positive cells in the bone marrow. And then after that, another log reduction to 1% is roughly equivalent to a complete cytogenetic response. And we know this, as I said before, from having looked at hundreds of results where we have both the cytogenetics and the PCR. And then an MMR, a major molecular response, is 0.1%. And this graph is actually the average results from some Australian patients in the IRIS study. So what this shows is that in the first 6 months, you have this very, very rapid, very steep reduction in the level of leukemia. And then after that, it slows down. And then we have this very, very gradual trickling down of the leukemia, but on average, things are still falling after a few years. Obviously, this is an average, and for an individual patient, it will be different, but this is overall what we expect to see on imatinib. And if you go back to the previous slide, we think that the reason why you get this very rapid drop at the beginning and then the slower drop later is because, first of all, we kill the mature cells, which are easier to kill. And then, once we've got rid of those, what we're measuring is these earlier cells, which are harder to kill, and because they're harder to kill, they drop more slowly. But in some ways, they're more important. So this is how we think about what the results are telling us. So as was discussed before, some people will continue falling, and they will eventually get to the stage where we can't see the leukemia anymore with a PCR test. This doesn't mean that it's completely gone, but it means we've got down to a very low level. And we ran a study in Australia with 40 patients who'd had no detectable leukemia for at least 2 years. And they were all monitored in Adelaide so that we had a consistent test result. And this is actually one of the patients who was in that study. So you can see that this patient had a very, very rapid reduction. They have this, for a while, sometimes positive, sometimes negative, which we see this kind of flick on and off, where we can just see the leukemia sometimes, and sometimes we can't. And then gradually, this person, after about 1.5 years, has been negative on every test that we did. So all of these green diamonds are tests in which we couldn't see anything. And so this person stopped imatinib. Here, where you can see the tests have suddenly become more frequent because we're testing this person every month, and that person is still off imatinib now after several years. So we know that there are some people who get down to a very low level in whom they may be able to stay off the drug for some time, which is something that we didn't really expect at all. So these are the results from the Australian study showing the proportion of people who were still PCR negative after stopping their drug. So you can see it starts at 100% when on the first day of stopping, and then gradually it drops to about 40%. So in our experience, we saw that about 40% of people remained PCR negative without their drug, and about 60% of the people had to go back on their drug, which is almost identical to the results which have been produced in the French studies of treatment stopping. And I think Eri is going to talk about this tomorrow. Sorry? Panel discussion. So we'll have a panel discussion about this later, because this is something that has caused a huge amount of interest, and it's a very important subject. So imatinib can do a very, very good job. How can we do even better? So we've already seen that not many people on imatinib will die from their leukemia, so it's actually very hard to show an improvement in survival. So then we have to look at other ways of estimating what the long-term outcome of the leukemia will be. We can look at event-free survival, where we talk about not just being alive, but also still being in chronic phase, still being on the same drug, still having a certain level of molecular response. And we can use these as measures of telling us who is more or less likely to have a good response in 5 years from now. We could maybe do better by making people's lives better because of having fewer side effects. Because we know that a lot of people on imatinib, although it's controlling their leukemia very well, they have diarrhea or muscle cramps or nausea, which have quite a significant effect on their day-to-day life. You know, I have patients who say, I take my tablets in the morning so I don't go out because I have to stay close to the toilet, and then in the afternoon I know it's okay. And things like this with a drug that you're going to take for 10 or 20 years can be really quite important. So maybe we could do better, not by changing the leukemia response, but just by changing the side effects. And then the other way in which we could maybe do better is to get more patients in a position where they can even stop the drug. I think at the moment that's still an area that we don't really understand very well, but a huge amount of work is going into getting a better understanding of what that means. And maybe in the future there'll be more and more people for whom the aim of treatment is to get off the drugs at some time in the future and have control of the leukemia without the need for expensive and potentially toxic treatments. So this slide kind of tries to summarize all of the main points of all of the 5 commonly available drugs in one go. So there's a huge amount of information here. So imatinib here is the comparator. So you know the standard dose is 400 milligrams a day, which is the dose that was used in the IRIS study. These are the concentration of the drug, which is found in the blood. So if you give somebody a tablet and then you measure the level of the Gleevec in their blood, these are the maximum concentration that you see and the minimum concentration that you see on average. And these are the mutations that we heard about before that can cause resistance to this particular drug. So starting first of all with the sort of the strength of the medication, the potency. So imatinib is the standard, so we've said that's 1, that's the standard. Nilotinib is about 25 to 30 times as potent as imatinib. Dasatinib is about 10 times stronger than nilotinib, 250 to 300 times. Bosutinib, which some of you may, I don't know if it's used in any Asian countries, but bosutinib is another of the sort of second generation of drugs. And that, like nilotinib, is about 10 to 15 times. And then ponatinib, the newest of the drugs, is the strongest of them all, and about 500 to 600 times.
How do you measure the strong or high?
So that's a very good question. So there are different ways of measuring the potency. So what this means is they've put a certain concentration of the drug in either with the enzyme or with cells that have the BCR-ABL in them, and measured an effect. So the effect that they're measuring may not be exactly the same, but this is a rough guide. The doses you can see vary enormously, and the concentrations vary enormously. So the fact that ponatinib is 500 times more potent than imatinib does not mean that it's 500 times better, because the amount of the drug that you get into your blood is much, much lower. So when you take that into account, it probably means that it's still stronger, but it's not as strong as it might look. So potency is only a rough guide to how that translates into a response for patients. The other important thing to notice from here is the number of resistant mutations gets smaller as you move down the list. So by the time you get to ponatinib, none of these mutations on its own will cause resistance commonly. You have to have more than one of these mutations working together to make the drug ineffective. You'll also notice that some codes come up again and again. So T315I blocks the effectiveness of all of the first 4 drugs. They're essentially more or less useless against people with T315I. But there are some other problematic mutations, particularly these 255, 253, 250. So this part of the BCR-ABL molecule, because these numbers are like a street name, they're like a street number. So it's telling you that these are very close together. So they're all part of an important part of the BCR-ABL protein. So this is looking at, is nilotinib better than imatinib? And the way that that's been measured here is by looking at the major molecular response rate. So this bottom curve is people who started on imatinib 400 milligrams once a day. And this top curve is people who started on nilotinib 300 milligrams or 400 milligrams twice a day. And you can see, regardless of which nilotinib dose you got, your chances of having a major molecular response, which is a very good response to treatment, were substantially improved at every time point where they looked. So although, as you'll see later, it wasn't possible to show a huge difference in survival, the chances of being dead or alive, the chances of having a very good response, which we expect will in the long term potentially translate into survival, are improved. And if you look at a deeper level of response, so this is MR 4.5, which is close to the limit of detection of PCR, this too is substantially improved by being on a second generation drug. Progression-free survival, so here focusing on transformation to accelerated phase or blast crisis, is also substantially improved by being on nilotinib. So there are equal numbers of people getting each drug, so nilotinib 300, nilotinib 400, or imatinib 400, and yet the number of people developing accelerated phase or blast crisis has dropped from 19 on imatinib to 9 or 6 on nilotinib, so fewer than half the number of people developing accelerated phase or blast crisis. So that's quite a significant improvement when you consider that a lot of those people who develop accelerated phase or blast crisis, if they're not transplanted, they will probably die from their leukemia. Overall survival doesn't show as impressive a difference. So the number of deaths we see here, 17 on imatinib, 13 on nilotinib 300, and 8 on nilotinib 400. The number of CML-related deaths is quite substantially reduced, so about a third as many on nilotinib as on imatinib, but there are still people dying from other things like heart attack or other cancers or the other things that people die from, and that makes it much harder to show a difference in total survival. And so this is showing what happens if you develop accelerated phase or blast crisis. So the first thing to notice is that this is another survival curve starting at 100% here. The dotted line shows 50%. But these times here, look, this is quite a short scale. So this is out to 3 years. Before I was showing you out to 5 or 6 years. So we can see that around half of the people who develop accelerated phase or blast crisis now, so this is not from 20 years ago, but this is from the last 5 or 10 years. If you develop accelerated phase or blast crisis, your chances of being alive in a year are about 50%. So if this happens, this is really a disaster. So we should be doing everything that we possibly can to prevent accelerated phase or blast crisis, because once it's happened, it's very, very hard to undo. And unfortunately, despite our best efforts, most people will still die. There are a few people you can see here. It looks like we can rescue about a quarter of the people, but that's really quite a small fraction. So preventing accelerated phase or blast crisis is extremely important. So those are the slides from nilotinib, mostly derived from the ENEST-ND study, which Novartis ran a number of years ago. So I'm now going to show you virtually exactly the same results for dasatinib, so that you can get some sense of the similarities between the two drugs. So here we see from the dasatinib study called DECISION, MMR rates again showing that they're better at every time point than with imatinib 400 milligrams, and similarly for a deeper level of response, MR 4.5, they're better at every time point, although the difference here doesn't look quite as impressive as for nilotinib. Here we see progression-free survival on dasatinib and on imatinib, and these curves are divided up according to how you were doing after 6 months. So if you were less than 10% after 6 months, you're on one of these top 2 lines on both drugs, and if you were more than 10%, sorry, that's after 3 months, then you're on this bottom curve. And you can see, regardless of which drug you were on, if you were on one of these top 2 lines, so that's less than 10% at 3 months, your longer-term outcome looks really excellent. The difference between the two drugs is that with dasatinib, there are more people on these top lines, and in imatinib, there are unfortunately more people on this bottom line. So getting that very early control of the leukemia translates into a later protection from developing accelerated phase or blast crisis. And interestingly, if you get into one of those good groups, it doesn't seem to matter which drug got you there. It doesn't really seem to matter whether it was interferon or imatinib or nilotinib or dasatinib. If you got into one of those safe categories, your chances of things going wrong are very, very small. And that's really almost surprising that the drug ceases to be important if you've had a very good molecular response. So the important thing with both nilotinib and dasatinib is we get earlier, faster molecular responses, and fewer people fail these molecular targets. This is overall survival again. So really no difference in overall survival, because although there are fewer deaths from CML, there were slightly more deaths, interestingly, for instance, from infection and other causes. So because imatinib already does so well, it's very hard to show an improvement. So just a few slides about the newer drugs, which are mostly not available. So, for instance, I've never treated anyone with bosutinib or ponatinib myself, because it's only been available through clinical trials, and there has been an expanded access program for those drugs in Australia as well, but very small numbers of patients have gone on to them. So this is the BELA study comparing bosutinib 500 milligrams versus imatinib 400 milligrams. So the bosutinib is the blue bar, and the imatinib is this kind of goldy yellow bar. And you can see, again, that at every time point, bosutinib was better than imatinib, and this is in major molecular response rates. But the study was designed to show improvement in cytogenetic response, and it failed to show an improvement in cytogenetic response. And so that has sort of delayed the development of this drug as a first-line treatment. But in fact, it does show improvements in deeper molecular responses. It also shows improvements in progression-free survival. So again, you can see fewer people who developed accelerated phase or blast crisis, and fewer people who died from CML. But the actual numbers here are very small, so this is not statistically significant. It's not scientifically proven that the risks are reduced. And then ponatinib, there was enormous excitement about ponatinib because very few cases have mutations which are resistant to ponatinib. The potency of the drug is very high, and molecular responses achieved very quickly. And there were studies beginning to test whether it could be used as a first-line treatment, just like nilotinib or dasatinib. But all of that suddenly came to a stop last year when the FDA issued a warning in relation to ponatinib because of increased frequency of mostly of stroke, but an increased frequency of vascular events in particular, but particularly of stroke. So if you look in the phase 1 and 2 clinical trials, which had treated people for only a relatively short time, after about a year of treatment, about a quarter of people had had a cerebrovascular event, so some kind of stroke or TIA. And in the phase 1 study, where people had more advanced disease but had also been on the drug for longer, it was almost a half. So because of concern about what the long-term risks of ponatinib may be, the clinical trials of ponatinib were abruptly halted. It's important to note that some of these events occurred within weeks of starting the drug, and some of these events occurred even in young patients who didn't have any cardiovascular risk factors. So these things, of course, raise enormous concern. So I think ponatinib has a lot to offer for people who have failed other treatments, and it may be the only thing apart from transplantation that offers any hope to these patients. So I think that there is still a place for ponatinib, but because of those non-CML risks, I think its use in earlier phases of the diseases is going to be put on hold for a while. And so currently I think that the company that make ponatinib is investigating whether lower doses should be used to improve the safety while still having good CML responses. So that's sort of the status of ponatinib. So to summarize, so these have all been studies looking at newly diagnosed people with CML starting treatment. So in general, they all show deeper and faster molecular responses. They also show a reduction in the number of people developing accelerated phase or blast crisis. And they all show a reduction in the number of CML-related deaths. But the overall survival is not substantially improved. And in some cases, particularly for instance, in ponatinib with vascular events, dasatinib with infections, and potentially in nilotinib with vascular events. The improvement in CML control is partly traded off because of new toxicities of the drug. So we have to be a little bit careful about this. So will these faster molecular responses mean that in the longer term, because these studies I've shown you have got data for 5 years or so, in 10 or 20 years, will these fast early responses mean a difference in overall survival? One would expect that they would, but of course we don't know that yet. Another question, if we have faster molecular responses and more people having a very deep molecular response, will that mean that more people will be able to stop their drug at some time in the future? Is that something that will be important in 5 years from now? And another question, are there any patients for whom a particular drug is favored? So are there any people for whom it would be wrong to start with imatinib? And I think at the moment it's quite hard to answer these questions. We haven't talked about the SoCal score. Does everyone know what a SoCal score is? So back in the 1990s, when the best treatment for young patients with CML was considered to be transplantation, you had to decide in which patients is the risk of the leukemia high enough that the risk of transplantation, where 20% of people will die in the first year, can you identify the people whose disease risk is so high that a transplant is the right thing to do? And so for that, SoCal and his colleagues developed a risk score where you looked at the size of the spleen, the age of the patient, the platelet count, and the blast count in the peripheral blood. And you put these factors into a complicated formula, and it gives you a risk score, which is either low, intermediate, or high. And this predicts the chances of dying or the chances of developing accelerated phase or blast crisis in people treated with older drugs, because of course this work was done many years ago before imatinib was developed. So these risk scores are a kind of a way of saying that this patient should be a little bit more worried about his disease than this patient here. So here we have the results from the INEST-ND study looking at the SoCal risk groups. So for each drug, so this is nilotinib 300, nilotinib 400, imatinib 400, and this is the SoCal score, low, intermediate, or high for each of those drug choices. So for a start, what you can see is that in imatinib, as the risk score goes up, the response goes down. So the black bars are people having a good response after 3 months. And so you can see as your risk goes up, your molecular response drops with imatinib. When you switch to nilotinib, the risk score doesn't matter anymore. There's a slight difference with the high-risk patients still doing a little bit worse, but it's almost equal. So we can say that nilotinib undoes some of the risk associated with the SoCal score. So it's bringing everyone up to a similar level. But you see also, no matter how good your risk is, there's still a very small fraction of patients who don't do so well on any drug, and that number seems to be about 5 to 10%, and we see that with pretty much with any drug. There's a very small number of people who seem to be destined to do badly from the very beginning. The dasatinib study didn't analyze the risk score in the same way. So they used the Euro score or Hasford score, which was developed later, and has most of the same things, but has a slightly different formula and also includes basophils and eosinophils. So they looked at the Hasford score rather than the SoCal score, and again showed that as you go from low to intermediate to high, the molecular response rates drop, so 65 to 57 to 43. Interestingly, on dasatinib, the molecular responses also drop, but you'll see that when you compare within a risk group, that it's always better on dasatinib than on imatinib. So dasatinib as well undoes some of the risk associated with your disease characteristics. And this is also from another study, again, really just showing the same thing, that as you go up risk group, your chances of having a CCR, MMR, MR 4.5 drops as you go through the risk categories. Now, the other thing is that the studies like Decision and ENEST-ND have compared one drug with another, but they've compared a particular dose. So they've all used the standard IRIS dose of 400 milligrams of imatinib. So it's clear that nilotinib and dasatinib are better than imatinib 400 milligrams. But can we do better with imatinib? And this is a very important question. If imatinib is the only drug available for most of your patients, then you have to do the best that you possibly can with the resources that you have available. So just putting everyone on the same dose of imatinib might not be the best way of using that drug. So a couple of studies have looked at this, and just very recently, so in the last few months, we've had this publication from the German CML4 study, which is one of the largest studies in CML ever conducted. So you can see here the number of patients on each arm. So this study started a very long time ago, so we now have 10 years of results from this study, with large numbers of patients in each of these groups, as you can see here, so over 1,000 patients in total. So this study compared the standard imatinib 400 versus a combination of imatinib and interferon, a combination of imatinib and the chemotherapy Ara-C or cytarabine, people who were given interferon first and then switched to imatinib, and people who started on high-dose imatinib with 800 milligrams instead of 400 milligrams. And so the imatinib high-dose curve is the blue one you can see here. So the best of all of these curves, and this is for achieving a deep molecular response, was imatinib 800. So this, if you compare it to imatinib 400, which is, I hope your color, sorry, I got too close then. I hope your color perception is better than mine, but I think that the imatinib 400 curve is this one here, right in the middle. So it's clear that for a deep molecular response, imatinib 800 is better than imatinib 400. So I guess that what we can say is that the studies which have shown that the second generation drugs are better than imatinib have shown that they're better than a dose of imatinib, which we now know is not necessarily the best dose. And if you compare, for instance, this is ENEST-ND, and what I've done is cut off the German CML4 results at 3 years, which is where the ENEST-ND results cut off. So you can see that in the best nilotinib arm, the rate of MR 4.5 was 32%, so about 1/3. And if you look at the high-dose imatinib arm, the rate of MR 4.5 was about 40%. So high-dose imatinib and nilotinib actually give quite similar results if you push the dose of imatinib to the highest that can be tolerated. Of course, this is not a randomized comparison, so it's not strictly a fair comparison, and the tests were done in different labs, which means that the rates are not directly comparable. But it suggests that if you use imatinib smartly, you can do better than just using 400. Similarly, in the CML4 study, they looked at survival. So there's a lot of information here, but just look at the survival thing. So roughly 400 people on imatinib 400, 400 on imatinib 800. And the number of deaths on low-dose imatinib was 28. And the number of deaths on high-dose imatinib was 12. So higher doses of imatinib kept more people alive. So if you look at that, it's clear that imatinib 400 really is not a very good standard. In Australia, we've run 2 tidal studies, which Tim Hughes has directed. So tidal was looking at starting people on 600 instead of 400. And we know from other studies that a lot of people can't take 800 milligrams of imatinib. The side effects are too severe for a lot of patients. So a couple of studies have tried to use imatinib 800, and what they show is that the average dose of imatinib that people actually got is about 600. So if you try to give 800, you usually end up giving about 600 because that's as much as people can take. So Tim designed a study where people started on 600, which is a more tolerable dose, and then by looking at molecular responses early on, if people were not doing as well as we wanted, we would then either increase the dose of imatinib to 800, or we would switch them to nilotinib. So these were Tidal I and Tidal II. So this is Tidal II, where people switched to nilotinib if they weren't doing well. And what you can see is that about 30% of people switched to nilotinib, and about 2/3 remained on imatinib. There were very few deaths. The total number of patients was 210, so that's a relatively small number of deaths, and a relatively small number of patients who progressed to accelerated phase or blast crisis. And when you look at the MMR rate and the MR 4.5 rate, or CMR undetectable rate, you can see that these results are pretty much as good as the studies I've just shown you for the second generation drugs. So in fact, the MMR rate here was about 80% at 3 years, and the deep molecular response rate was about 40% at 3 years, which is very similar to the German CML4 study and similar to Decision and INEST-ND. So I think both of these imatinib-based studies from Australia and from Germany suggest that you can do better with imatinib if you use it smartly. In the laboratory in Adelaide, there's been a lot of research on optimizing the use of imatinib, and this is just one slide from the work that Deb White has done. So Deb White, in collaboration with the Australasian Leukemia and Lymphoma Group, which is our clinical trials network for hematology, and with Tim, has looked at factors that determine. So when you take a dose of imatinib, in order for it to work, first of all, the tablet has to get into your bloodstream. So it's no good if you swallow the tablet and then none of it is absorbed, or if you vomit it back up or whatever. So first of all, the drug has to get from the tablet into your bloodstream, and then it has to get from your bloodstream into the leukemia cells so that it can kill the leukemia cells. So what matters is not the dose of imatinib that you took, but the amount of imatinib that finally ended up in the leukemia cells. So the dose is a very rough guide to what is going on inside the leukemia cells where it matters. So what factors influence how much of the drug gets into the leukemia? And what Deb White has found in many, many years of research, which has been supported mostly by Novartis, is that OCT1, which is a protein present on the cell surface, OCT1 transports the imatinib from the bloodstream into the leukemic cells. So if you have low OCT1 activity, shown here in the dotted lines, or high OCT1 activity, and you're on a standard dose of imatinib, so that's here 400 milligrams a day, the low OCT1, where the imatinib gets into the cell inefficiently, these people have a much lower chance of achieving a major molecular response. If you have high OCT1 activity, so that drug pump works very efficiently to suck the imatinib into the leukemia cells where it matters, then even on a low dose of imatinib, you're almost guaranteed to do well. And this OCT1 activity, we don't really know, but we think it's basically just something that you're born with. You either have a high OCT1 or you don't, and we can't change it. That's just how you are. So I guess that this is starting to help us to understand why 100 people given the same dose of the same drug have different responses. So some of it is due to how the body actually handles that drug. if you increase the imatinib dose to 800 milligrams, and this is from the Novartis TOPS study, which was run globally quite a number of years ago, if you increase the dose of imatinib, then what happens then is that the difference due to low OCT1 activity is partly reversed. So if you pour in more Gleevec, then the fact that it's transported inefficiently is no longer so important. It doesn't completely undo the bad effect of low OCT1 activity, but it substantially improves that gap between the two different doses. So I guess that what we think is that if I knew that you had high OCT1 activity, I would be fairly confident that you were going to do well on imatinib 400 milligrams, and there may be no advantage to being on a higher dose of imatinib, and there may be very little advantage to being on nilotinib or dasatinib or bosutinib. Unfortunately, this is available only as a research test, and we've never been able to do the large clinical trials to determine whether that's actually the case. So at least it gives us some understanding of why people differ in their responses. So I'm going to move on now to the second line treatment. So that's people who've started with imatinib and then they've switched to another drug either because of intolerance or because of an unsatisfactory response to treatment. Perhaps I might pause here if there are any questions about first line treatment. I have to pause partly because I think you need a chance to ask questions, and partly because my voice needs a rest. So are there any questions?
Hi, for the OCT1 studies, right, is there a way that do we know that we can boost the OCT1, the protein within a human so that it can improve the efficacy of the transportation?
So that's a very good question, and Deb White and her group looked for a panel of drugs that might change OCT1 activity, and they came up with some candidates, but there was nothing that makes a huge difference to the OCT1 activity. And the problem is if you add another drug to imatinib, then you may potentially increase the side effects. You know, if you have to be on 2 drugs instead of 1, then you have potentially 2 different types of side effects. So scientifically, it's an excellent question, but from a practical point of view, we didn't find anything that would be a good combination partner. So we haven't found that. But, you know, it's an excellent question, and if it's possible that in the future a drug company might invent a drug that does that, but there isn't a good first choice.
Yeah, I have a very simple question. I'm actually a risk manager by profession. So looking at all the presentations and the slides that you've given, isn't that a case in point to have a very simple risk score and risk color, say red, white, red, amber, and green to a traffic signal? So you tell the patient, okay, you're in this zone, and I know like how we do the blood reports and the routine reports that we do, annual medical checkup, they give you a heart zone, they give you a blood zone. Yes. Similarly, I mean, looking at this, we could develop or devise a risk score and a color for each patient and the generation TKI so that there is a mapping available, which TKI could be given to which patient with which risk score or risk color.
Yes, unfortunately, it's too hard. So if I see someone newly diagnosed with CML, I can't tell if that person is going to do beautifully on imatinib 400, whether they need nilotinib or dasatinib. There is nothing that can really tell. The SoCal score or the Hasford score gives you some indication. So personally, if I see somebody with a high-risk SoCal score, I would start them on nilotinib or dasatinib. I would not start imatinib, because in my country I have that choice. But even that is not scientifically proven. No one's ever done a study that I'm aware of that has shown that in high-risk SoCal they do better if you start nilotinib or dasatinib. But really that's the only thing apart from scientific tests like the OCT1 that might give some indication of where you should start. If, on the other hand, you start a drug and then you come back 3 months later and do the PCR, then we can start to say this person is in a good group or a bad group, and that's exactly what the ELN guidelines are for. So the ELN guidelines essentially do tell you, are you in the red, green, or yellow group? That's more or less exactly what the ELN guidelines try to do. So we'll talk about that more in my last talk. Thank you.
Doctor, in your slide you show the many mutations of imatinib. Can you briefly summarize what are the most common mutations that may result in drug resistance?
So those were that list. It's probably too far for me to go back, but for imatinib, I think there are over 40 mutations which have been reported, but the commonest mutations were on the slide. And then for nilotinib and dasatinib, the number of mutations is smaller. The number of people who get mutations is less, and the number of different mutations is smaller. So the newer drugs are less susceptible to develop mutations.
Are those most common mutations IM related to various split points of BCR-ABL or other reasons?
Well, we think, so this is very complicated and I don't have any drawings to show you to help, but the way that imatinib works is that the BCR-ABL is an enzyme, so it's a protein which acts as a switch, and it turns things on and turns things off. And the way that it turns them on or off is by taking a chemical called phosphate and attaching phosphate to another protein. So what happens is the BCR-ABL binds to another protein and it carries a phosphate and sticks it on to the other protein. And we think that what happens is when imatinib binds, it prevents the phosphate from being moved onto the other protein. Now, the way in which that could happen is very complicated because it could interfere with the phosphate transfer, it could interfere with the binding to another protein. So it's very, very complicated. But imatinib sits on the BCR-ABL protein in quite a specific way. And if the BCR-ABL protein changes its shape, then imatinib can't lock anymore. So small changes in the shape of BCR-ABL will stop the imatinib from working. The nilotinib and dasatinib both have we think a more flexible binding, which means that only certain changes matter. A major research aim at the moment is to develop new inhibitors where this precise fitting together doesn't matter anymore. And so a number of companies are trying to develop these new inhibitors that work in a different way, that don't just simply block the transfer of phosphate from one protein to another. So I think it's been more than 5 years since the first of those drugs was invented, but none of them has yet made it into clinical practice. But people are trying. Sorry, yes?
Does a 2-week drug holiday from imatinib affect the response of the patient?
So that's a good question. I would say that early in treatment it does. We looked in the TIDAL study at the dose of the drug that people received in the first 6 months, and people who missed 10% of their dose in the first 6 months, so that would be 18 days out of the first 180, those people did worse than people who took their drug constantly. So even missing a relatively small number of doses early in treatment could potentially have a long-term impact, because we think that that early drop in the leukemia is very important. Whether missing a week or two 5 years down the track, whether that matters, we don't know. But certainly in the early in treatment, I always tell my patients it's important they take every dose every day, because you want to get quick control. Later, it might be different, but we don't know. Certainly, I have a couple of patients who either have become pregnant after being diagnosed with CML, so women who've had a baby, and I always tell them you should have at least 2 or 3 years of treatment before you stop to try to become pregnant, because you want to get the leukemia down to a low level before you take any chances.
Could we move on to the next topic so that
Yep.
we'll
we're
have
running
time
out of
for you to both? And then
Yep.
if there are questions, then we can always take it maybe
Yep.
during tea. Thank you.
Okay, so so for people who have been on imatinib and have to stop it because they've developed side effects, so they're unable to tolerate imatinib, then how do you decide which of the other drugs to switch to, whether to switch to nilotinib or dasatinib? So the things that we take into account would be other medical conditions. So we know that there's some concern with nilotinib about pancreatitis and about vascular disease. So if someone has risk factors for these things, then you might prefer to switch to dasatinib instead of nilotinib. With dasatinib, there's concern about infection risk and lung disease, particularly pleural effusion and pulmonary hypertension. So if someone had risk factors for those conditions, then you would prefer nilotinib over dasatinib. For someone who's otherwise perfectly healthy and doesn't have any other of these things to worry about, then really there's no clear decision as to which would be the better choice. Dasatinib is taken once a day and you don't have to fast. Nilotinib is taken twice a day, and you have to be careful about the food that you have when you take nilotinib. So convenience is sometimes a factor. So for instance, I have some patients who they work night shift, and so they have their meals at strange times, and so taking nilotinib around meals was very difficult. Or someone who was a long-distance driver, so he does deliveries and he drives thousands of kilometers across Australia to deliver things. So for him, having to work his meal times around taking his nilotinib was impossible. So those patients may prefer to be on dasatinib. Most of us who work a 9-to-5 job, working nilotinib into our routine is not so difficult, but there are some patients in whom the convenience may be a factor. If you're changing drugs because someone has become resistant to imatinib, then the first question is, does this person have a mutation? Because certain specific mutations predict either a better or a worse response to nilotinib or dasatinib. So if you have one of these mutations, dasatinib would be better. If you have one of these mutations, nilotinib would be better. If you have T315I, then the only TKI that works is ponatinib. So neither nilotinib or dasatinib would be the right choice. So currently, if you have a T315I mutation, then really it's a transplant or ponatinib. And if you have compound mutations, which is where you've developed multiple different mutations at the same time, this is quite rare but does happen, then even ponatinib may not work. And so if you're in that group, then your best choice is a transplant, unless there's some experimental treatment available to you. Around 50% of people with imatinib resistance have a mutation, and around 50% don't. So for the people who have no detectable mutation, then you're really left choosing for the same reasons as before, choosing because the person has lung disease, choosing because the person has diabetes, or choosing because of convenience. So it really comes down to what you have available and what will suit your individual patient. So I'm then going to move on to summarize the phase 2 studies in which nilotinib and dasatinib have been used after imatinib. So these 2 studies are nilotinib and dasatinib. So similar number of patients, somewhat similar follow-up. The resistant patients were about 70% in both studies. Most people had tried a higher dose of imatinib before stopping. You can see that they'd been on imatinib for quite a long time. Around just under half had mutations, as you'd expect. And they had the nilotinib group was a bit worse in the number of people who had a major cytogenetic response when they started the phase 2 study. So it's always very hard when comparing two different studies which have been conducted differently, because the results don't mean exactly the same thing, but this is the best way that we have to compare the two drugs. There's never been a study that I'm aware of that has actually given half the patients nilotinib and half the patients dasatinib. I think that the two companies would never work together to do that. Perhaps I shouldn't say that, but I think it doesn't happen in the commercial world. So here are the results for nilotinib. So in this group of patients in whom imatinib was no longer working, this is progression to accelerated phase or blast crisis, and you can see that the results look nowhere near as good as those which we saw for newly diagnosed patients. If you look at those patients who were resistant to imatinib versus those who were intolerant of imatinib, you can see that the response rate to nilotinib is better for the people who are intolerant than for those who are resistant. So if you're switching because you got side effects on imatinib, you probably do better than someone who became resistant. And when you think about it, that kind of makes sense, because the development of side effects is just kind of bad luck. The development of resistance, I think it tells you something about the aggressiveness of the leukemia as well as about the way that the drug works. So that's more important in a way than the side effects. Here the curve for dasatinib, again showing progression-free survival, shows also that people who were intolerant of imatinib did better than those who were resistant of imatinib, and overall the survival curve looks a little bit better than it did for nilotinib, but the group of patients going into the study and the definition of progression was not exactly the same, so you can't draw a direct comparison. If you look at the proportion of people who were still taking that drug, so in the nilotinib study, 60% of them had come off at the time when the study was reported. And the major cause of stopping nilotinib was an unsatisfactory response. So these people had not done well on imatinib, not done well on nilotinib. They were going to try another drug. On the dasatinib study, at the time of reporting, 70% of people were still on. And interestingly, most of those who stopped had stopped because of side effects, and a smaller proportion of people had stopped because of an unsatisfactory response. So I think it's hard to say that dasatinib is better than nilotinib in this situation, but that's what these results tend to suggest. But as I say, there are some caution about how you interpret that. What about if you've had imatinib and either nilotinib or dasatinib, and now you need a third drug because of resistance or intolerance? So this is where bosutinib has been used, and you can see here this very messy curve showing the probability of being alive and still in chronic phase. So if you look at it overall, you see that something like 2/3 of patients will do reasonably well on bosutinib. And if you look here, you'll find that people who are intolerant are those who are doing best. So those who are intolerant to two previous drugs tend to do very well on bosutinib. Those who were resistant to their two previous drugs tend to do a bit worse. So that's kind of the same theme coming out again. So this will work well for about 2/3 of patients, but unfortunately some of these people will need a fourth treatment. And then here ponatinib And this is after people who'd failed either nilotinib or dasatinib, and they may have had imatinib as well. Here is the survival curve. So this is not progression-free survival, but just dead or alive. And you can see a very promising-looking survival curve out to about 2 years. So there was enormous hope from ponatinib when we started to see the first of these results. But as I say, there's now caution about the toxicity. So to summarize this second part of the talk, the newer drugs achieve higher response rates in first line and higher response rates after failure of imatinib or intolerance to imatinib. Despite that, the results are still not as good as people on their first line drug. So my message from this is that you should try to choose the best treatment on day one. You know, the best results occur if you start the right drug at the very beginning. The problem is we don't know which is the right drug. We still don't know for each individual person which is the best. So I have these very difficult conversations with my patients. In Australia, we can start imatinib or nilotinib or dasatinib as the first choice. And people say to me, well, which one is the best? And the answer is there isn't a clear best. There are some things which will steer you more one way or more the other way, but it's not, this is the first choice. It's not as simple as that, unfortunately. So try to choose the best drug first time, but that's hard.